Jonas is a practicing family physician, an expert in integrative health and healthcare delivery, a widely published scientific investigator, and author of the book, How Healing Works. Dr. Jonas is the Executive Director of Integrative Health Programs at Samueli Foundation, which funds innovative research in integrative medicine, disease prevention, and health policy. From 2001 to 2016, he was the Chief Executive Officer of the Samueli Institute, a nonprofit medical research organization supporting the scientific investigation of healing processes in the areas of human performance, stress, pain, and resilience. Dr. Jonas is a retired lieutenant colonel in the U.S. Army Medical Corps, where he served as a researcher, physician, and medical educator. He was the director of the National Institutes of Health Office of Alternative Medicine from 1996 to 99. And prior to that, was the director of the Medical Research Fellowship Program at the Walker Reed Army Institute of Research. Dr. Jonas has served on the White House Commissions on Veterans Healthcare and Alternative and Complementary Medicine. He also served as the chair of the World Health Organization Center of Traditional Medicine. A graduate of Wake Forest University School of Medicine, he is a fellow of the American Academy of Family Physicians and is a clinical professor of medicine at Georgetown University. His research has appeared in peer-reviewed journals such as Journal of American Medical Association, Nature Medicine, Journal of Family Practice, Annals of Internal Medicine, and The Lancet. Dr. Jonas is a graduate of the class of 1977 at Davidson College, where he completed his senior thesis, Medicine for a New Age, through the Honor Center. He lives with his wife, Susan Cunningham Jonas, also class of 77, in Alexandria, Virginia. And so now, without further ado, let's get started.
Thank you, Judith, and thank you, Lauren, for setting this up. Thank you to the class 77 for inviting me, and thank you, Davidson, for setting up a platform to allow me to pursue my passion and to hopefully do good in the world. I first need to apologize because I've got a cold. And it may be appropriate, actually, that one type of coronavirus can get our attention and we can do miracles with it. Get rapid vaccine production. We have treatments now that are emerging in that area, and get rid of it or control it within a couple of years. And another type of coronavirus that produces the common cold, we haven't been able to figure out yet. Nothing like a crisis to create an opportunity to motivate people to get into action. So I appreciate that, but I want to apologize. I think I'll be able to get through this talk without too much coughing and hoarseness and that type of thing. So we'll do that. So I'm going to do the typical thing and share my slides just to get on the train here and get some information out to you so we can begin to talk about that. So you may notice by this slide that I have changed the title of the talk. Now, don't worry, I'll talk about what the original title had, which was How Healing Works. That's embedded in this talk. But in talking with my wife, Susan, she said, I think this group might be interested in a bigger picture, especially some of the policy work that's being done and the large system change efforts that are going on. So when I started to work on that, I realized that sort of How Healing Works was too limited a component of that, but I will talk about that. I'm calling this the case for whole person care, people, practice, paradigms, and policy. So first of all, I'd like to thank Sue McAvoy, who's been leading our class in many ways for so many years. My wife, Susan Cunningham Jonas, or as Sue McAvoy called her, Cunningham, when she was there. And I want to thank Stretch, who's taken on the mantle of organizing our reunion here, this 45th reunion, and Jeff, who's been supporting that, as well as Judith, Len, Lauren, and all the class of 77 that is doing this. I think I was in the military and I do the bottom line up front, which means tell me what you're going to tell me. And I'll tell you here that friends and family are the true source of healing. We'll get a little bit more complicated than that, but ultimately it comes back to that. So Judith and Lauren asked me to talk a little bit about how Davidson influenced efforts. And you just heard about a bunch of stuff that I did after Davidson. So I thought a little bit about, well, how did some of the things that happened at Davidson sort of set me up for that? And so I identified kind of three sort of key or formative events from my experiences at Davidson that I think were key to this. And one of them is that we were in the first class of pioneering women. That's probably the greatest thing that Davidson's ever done. They still inspire us, they lead us, they push us, they influence us, they balance us in those areas. And I can't say that I, as a man who went to Davidson during that class, did anything different than what had been going on for a long time before that. But I know that group, especially that group in the group in this class, 77, I know from personal experience are pioneers. Second, Judith mentioned the Honor Center. Now, I don't think that's around anymore, and I'm sorry to hear about that, because it had a profound experience on my ability to kind of figure out, what I thought was important in life and to then pursue that. That was a center where you could pretty much create your own major. You had to apply for it. If they thought you were good enough, you could then sort of piece together a major from courses inside and outside the college. And that allowed for the broad kind of thinking that I was interested in, and what I say creative learning, rather than having to follow a particular path. Now, I'll have to say you had to have a faculty member. Many of you may remember Sam Mahoney. Why a religion professor took me on when I was really doing something in cultural anthropology and health and that kind of stuff, I'm not sure. But anyway, he was kind enough to say, all right, I'll be a sponsor and I'll help him focus a little bit. I'm not sure how successful he was at that, but anyway, that was very formative. The second thing was an early acceptance program into medical school that Davidson had. I, again, don't know if they still have this, but if they don't, I would strongly urge them to look at it for several reasons. I applied for that, as did another one of our classmates, John Umhow. And we were accepted into Wake Forest School of Medicine 2 years early. That meant we knew at the end of our sophomore year we were going. We didn't go until we completed the degree at Davidson, passed all the tests, took the MCATs, et cetera. But what it did is it freed us up to really pursue the broader areas of healing that are needed to be, good healthcare, and that I'll talk about in a minute. It removed us from the 4.0 requirement treadmill to get into medical school, and it allowed me to go around the country, in fact, outside of the country, to learn about the world's healing traditions. One of those things was a month spent at this counterculture place out in California called Esalen, where there was a month-long course introducing you to things I wasn't going to learn in medical school: Tibetan medicine, Chinese medicine, and acupuncture, massage, structural therapies, Ayurvedic medicine, traditional Indian medicine, herbalism, et cetera. And I learned very early, even before I went to medical school, that there was more to the healing philosophy than I was going to learn, Horatio. The third thing it allowed me to do is it allowed me to pursue something that my father did as a chaplain, and that is getting CPE certification and working for a long time as a hospital chaplain. Now, I knew I wasn't going to be a hospital chaplain, but I knew from my experiences with him and discussions with him that spiritual healing and the spiritual dimension of a person was key to healing. And so I was able to go up to Union Theological Seminary in Richmond and be a student CPE trainer for several months, where I saw what it was like to be the chaplain from the inside within a healthcare setting. So thank you, Davidson, for those opportunities. The rest you've heard about in those areas, but that was my little Davidson spiel. So now, Let me start by first introducing you to a patient. This is a real patient. This is not her real name. To show you what happens when you have really good health insurance and really good healthcare coverage. This woman, Cynthia, was an executive at the Pentagon. She had full access to all specialties, all primary care, all drugs, all procedures. She had platinum level healthcare insurance. She also had a car accident. And she got on what many patients get on when you develop a chronic back pain, a neck pain. She started the pill and procedure treadmill. She started pain medications, including opioids, which she liked the best, and continued, and the anxiety medications, sleep medications, muscle reductions, got injections and surgery. 10 years later, she had quit her job. She was on disability. And then she came in to see me and say, "Doc, how can you help me?" And that's a long time of having platinum level healthcare. Here's some of her team. And this, I shouldn't call this team because they didn't work as a team. And all of us has experienced the fact that our different practitioners actually don't work very well as a team. Things work better when they do. But she had primary care doc, physical therapist, pain specialist, surgeon, behavior. They all did what they needed to do very well, but they didn't actually coordinate her care. Notice she also had several addiction specialists trying to get her off of opioids. Now, you've heard about this little thing called the opioid epidemic. I think it was probably the only term epidemic that was in the news for a couple of years prior to the pandemic. And this was because there was good reason for it. There was a growing death rate from opioid overdose, and we were not actually doing much to contain it. Every state in the union, 2 presidential commissions, multiple other organizations said, we need to do this differently. And then the pandemic came along and it got worse. In 2017 and 18, there were about 70,000 deaths from opioids. And in 2020 was 93,000. And I think 21's numbers are even higher than that. These commissions that studied this told us what to do. They said, stop using the drug and start using non-pharmacological approaches. These recommendations came out from groups like the American College of Physicians, the VA, the Joint Commission that accredits hospitals, the FDA, Department of Defense, et cetera, in those areas. And when I saw that, I said, well, patients are already doing that. Sally was doing it a little bit, but she didn't really have the guidance. I mean, Cynthia didn't have the guidance to do that. And also, I hadn't been trained in medical school how to do those things, even though I'd experienced them and seen some of them. And many of them were not particularly evidence-based. But these guidelines actually selected out the science or the evidence-based ones and said, those are the things we should do. And I'm hoping that in medical education now we start doing this. Needless to say, we began to incorporate that. By the time Cynthia saw me, there actually was an integrative health program in the Fort Belvoir Community Hospital for chronic pain patients where I work. And we began to help her incorporate some of these things from the recommendations into her life. Things like yoga and stress management. We provided her with a health coach to help her in behavioral assistance. Most medical care says, here, do this, but we don't actually have the behavioral support to do it. And then when they don't do it, we say it's a compliance problem. We needed mental health support, but Sally wasn't crazy. She was certainly affected and had some depression from this. What she needed is really an ability to work with others to mitigate the loneliness that these chronic diseases produce that creates an ongoing downward spiral in these areas. And then she needed new modalities that had been demonstrated to be effective in chronic pain, an example of which is acupuncture, certain types of manipulation and massage, for example. She started on these things now with a coordinated team that only involved really one physician and some behavioral science, science support, integrative medicine trained folks, not physicians necessarily, but things like acupuncture and yoga therapists, officially trained in doing back pain related yoga. And she began that process. And within a period of about 3 months, remember, she'd had this for over 10 years, she began to feel better. Her pain levels dropped, her functional levels dropped. And within about 6 to 7 months, she was actually ready to go back and look for a job. She was not cured, but she was on her path to healing. Now, this approach is a new type of care. It is a combination of the conventional stuff that I learned in medical school with non-drug approaches, sometimes called complementary or integrative medicine, and self-care and behavioral change. It's then at that intersection that the new approach is needed. And this applies not only to pain, but it applies to the vast majority of chronic diseases that afflict our society today. To put it a different way, we need to bring the patient into the care process and support them in their own healing. When you normally go in and see a doctor, they ask what's on the right, what's the matter, and provide things to try to cure or treat. But healing involves working with the person, not just a patient. It's not patient-centered, it's person-centered. And we ask, first of all, what matters to you in life? And then linking that to support approaches that can facilitate the underlying determinants of care. From a healthcare policy perspective, this is a very important thing to think about for those of you that either are for or against universal healthcare insurance. The question is not how do we get more healthcare, but how do we actually get health and well-being, and is healthcare part of that? And as I'll illustrate to you right now, if we just stay up in the conventional area and do not expand to more of this integrative care, health is a diminishing part of that. This is all before COVID, some of this data before COVID. We are first in spending in healthcare. We are 37th by almost any metric of chronic care problems by the WHO, comparing it to other countries. We're on track to spend 20% of our gross national product by 2025. And with that increasing cost, health disparities are also increasing. The difference between the haves and the have-nots is growing. There's growing widespread dissatisfaction, and there's growing burnout among providers in trying to stay on the treadmill of treatment. By almost any metric, healthcare is not worth the cost anymore. Here's a report that came out from the National Academy of Medicine back when it was still called the Institute of Medicine, but many, many other reports have come out. I like this one called Shorter Lives, Poor Health, because it tracked the major rich countries over 30 years, and it looked at their ongoing health outcomes and costs. And the United States fell behind most of those countries in very important areas. And here's a list of the ones that they actually declined, as well as pain and pain management in those areas. This chart illustrates the declining value, I think, very clearly on one graph. This is looking at life expectancy compared to the amount of costs on health per capita. And as you can see, the United States is a major outlier. And the additional life expectancy is somewhere around Czechoslovakia or Portugal, who spend much less on healthcare in these areas. Now, it's no mystery as to why this is happening. There's also lots of data on this. Probably the best source of data is the Wisconsin County Health Determinants website that tracks county by county the contributions to health around the nation. And they've consistently reported over decades that full medical treatment only adds about 15 to 20% to actual health in a population. That's because the underlying determinants of health are social and economic and behavioral and lifestyle. Pardon me. They are, in fact, produce the other 80% almost in those areas. One, it's like, I was hoping I could get through this. And so if we're going to actually produce health from healthcare, we got to get out of this black box up at the top and get into the underlying determinants of health. Now, along came a little thing you might have heard of. It was called COVID, SARS-CoV-2. And this has flayed open the weaknesses and the need for transformation in these areas. COVID has had a huge impact on physicians. 25% have permanently lost members. 20% of the healthcare force has left. 41% cannot fill staff roles, and close to 50 or more percent have mental exhaustion, or sometimes called burnout. Family decision makers are suffering from more mental health crises, so-called diseases of despair, obesity, addiction, community violence, and racial disparities. Healthcare executives are finding that they've had to paddle water to maintain patient care. The revenues have declined. The rural systems, especially those without deep pockets, have been closing. And most of the quality improvement things, the things that would actually get healthcare better, were put on hold during those 2 years. And it's not over when it's over. We don't know if it's over yet, but I can tell you when it is over, it's not over. And that's because we've now discovered that close to a third of the patients have persistent symptoms. The people who died during COVID were the same people who had chronic illnesses that we hadn't addressed effectively. You may have heard them called risk factors in those areas: the elderly, those with chronic diseases, many people of color, low income, those in poor healthcare, and more those who could not isolate themselves on Zoom in service jobs. Those were the death rate that occurred during COVID was accelerated. We were already having the decline in the death rate before it occurred, but it was markedly accelerated. It was found that within a single year in 2020, the life expectancy within the United States declined by an entire year. Unbelievable drop in our life expectancy. And now data just a few weeks ago that came out on 2021 showed that that has continued, or it continued through 2021. And so over the last 2 years, we have had a 2-year life expectancy decline. The persistence of symptoms that I've mentioned, and I see a lot of patients with long COVID. The disease is gone. Well, the virus is gone, but the disease is there, and it hits many, many, especially in the area of fatigue, for example, where they can't get up and function. It hits every single organ. So there hasn't been a single tissue cultured during an infection that at some point they haven't found the virus in. And those that have had it, even if they haven't been hospitalized or had severe disease, are at higher risk later for dying in those areas. And so this is not a disease that is going to go away. So before COVID, after COVID, we still need a whole person care approach in those areas. And here's some questions I ask my long COVID patients. And if I don't do that, then I'm not treating them comprehensively. All right, so what does this all mean? Okay, why do we need to actually change the way we do? And if so, how can we do that in those areas? I think there are 3 things that are needed in order to make that kind of social, cultural, and system change. 1, we need to see things differently. 2, we need to do healthcare differently. And then 4, we need to demonstrate value. We need to actually show that what we're doing is actually worth what we're putting into it, and put that into accountability component. Let me talk a little bit about each of these briefly. Seeing and communicating differently, we need to change our mindset. As a family physician, we've known for years that chronic disease is best treated when you take into consideration the whole person, mind, body, and spirit. And yet our system takes a mechanical mindset, a reductionistic approach, which you want when you need that approach. If you need a tumor removed, if you need a knee replaced, if you're having a heart attack, if you've been in a car accident, boy, everybody in the world wants the type of system that we have. But when we extend that to chronic disease management, it does not work and produces and is in fact counterproductive. The ecological mindset or whole person mindset, it's what's needed there, that addresses not just the body and the mechanical components, but behavioral and lifestyle, our social and emotional body, and our spiritual and mental care. Therefore, we need an evolution from what I showed you at the beginning that I did with Sally, from so-called integrative care to what I call whole person care. And this is for anyone with chronic disease, in which has at least these 4 dimensions: the body, the behavior, the social and emotional, and the spiritual assessed in some way. And I'll show you some tools for how that's done. Here's some questions that is in one of those tools that I'll mention in a minute. And as you can see, it asks the patient what their home is like, their environment, whether they're exposed to nature. It goes through the behavioral components that we all know are important for maintaining and even reversing some chronic diseases: diet, sleep, stress, and activity. It deals with social and emotional support, not because the expectation is that you have a mental illness, but because the expectation is that you're a human being. And social and emotional support is a key part of that. And then finally, the spiritual and the mental component. What do you live for in life? And is that aligned with your own health maintenance? And that is integrated into a personalized health plan. Now, there are many organizations that are doing this. And let me just show you one that we've been part of. Admiral Mike Mullen, when he was chief of staff several years ago, helped develop the Defense Department's whole person care approach. They called it Total Force Fitness. COVID and a couple wars sort of put the real focus on that on hold for a bit, but about a month ago, they pulled it up, and they've really now started to measure this in all service members in order to build their resilience and to improve their health. So the Defense Department, as frequently is the case, is first out in whole person care. The Veteran Administration has also adopted these types of things. This is something called whole health. They were already moving towards whole person care in the mental health area, and over the last 2 decades, the VA care has gone from not all that good to being better, especially in mental health care and whole person care, than the civilian sector. A number of studies have documented this over the last several years. So they've really been improving in those areas. Here's a model called Advanced Primary Care that I presented to a National Academy study of implementing high quality primary care that shows how these kinds of things can occur and where the former component of integrative health on the left-hand side fits into that whole person care model. Those words and those framings and others were taken up by a recent publication from the National Academy of Sciences, Engineering, and Medicine called Implementing High Quality Primary Care. And you can see right here from the definition that whole person integrated, accessible, and equitable care is right in the definition and then delivered throughout their recommendations through the administration. The administration has picked this up. Okay, there is now a unit within the Office of the Secretary of Health, Office of Assistant Secretary of Health within HHS, that has picked these and other recommendations up and has launched a new primary care transformation initiative that we'll probably hear about more in the coming years. One of the major things that was a gap in this area was payment. In the old model, in the mechanical model, you pay for a procedure, you pay for an interaction, you go in, you see the doctor, they put it in a CPT code, and then if you have health insurance that covers that, then you'll get it covered. But a lot of stuff in this area falls out of that. Okay, it just hasn't been brought in. Even the evidence-based work, like I've shown you with Cynthia and her pain problem. So our foundation has supported with 4 other foundations a new study that is ongoing right now. It's called Financing That Rewards Health and Well-Being. And again, it's focused on how do we have a financing structure that we can actually deliver health and then reward the system for doing that. There's a term that's called value-based care, where you pay for the person, you pay for the care, and the quality of the care is key in those areas. Here is an approach that if any of you are system leaders or work in a system, that we found was very helpful in communicating how to actually do this in your system. The VA is now picking this up, and there's a comprehensive National Academy study sponsored by the VA to study how they can implement this further. That came out of a commission that I was on called the Cover Commission. You can look up that report, but this is called the two-circle model of whole person care. And what it does is it takes the medical services that you normally get on the right-hand side, and it integrates it with the recovery services or the healing services on the left-hand side, and uses a team care approach, not just a physician care approach, to actually implement that. This has been adapted now for the civilian sector, and there will be a movement coming out probably next month to begin to implement and discuss this within the mainstream non-military, non-VA sector. What's interesting about this is that the terminology is very important here to understand, because we have a lot of terminology going in this direction. People have wanted to do this for a long time. But this particular model uses terms like person-centered rather than patient-centered care, relationship-based rather than transaction-based, and it focuses on delivering recovery services, not simply treatment services. It starts by addressing what matters, doing a team approach, organizing focused support recovery services, and having a payment system that takes the handcuffs off the healers and allows them to adapt and personalize the care for what they need. So if we change our mindset, change our policy, and even if we don't, we still need to do healthcare differently. And in fact, those of you who are doing healthcare or have engaged in a healthcare system, even those of you who are not in healthcare, I'll show you how to do that. You can engage in healthcare differently right now without those kinds of policy changes. And one of the things our group has been doing is recreating the tools. You can't get to a healing approach with the tools that we currently have. You have to adapt those. And in the two-circle model, that's being done. Otherwise, you're eating soup with a fork, and you're not going to get very much. So what are some of those tools? Well, this is a common tool that's used in the treatment side. It's called the SOAP note. And your physician uses this every single time you walk into his or her office or their office. This is built into the electronic health record. It's built into the reimbursement system, built into pretty much everything healthcare delivers. It's called the SOAP note. It stands for the subjective. This is documented what the patient says. The objective, the tests and exam. The assessment, which is a diagnosis that has to have a certain code if it's going to be paid for, and a plan. And the plan is addressing that assessment. It asks the patient, what's the matter? For the most part, it's very materialistic and reductionistic. It focuses on doing things mostly to the physical body, and even in mental health, doing things chemically, often in those areas, are paid for much more extensively than the psychosocial components of it. This tool does not work for healing. And so we have put together another tool that we're now training individuals around the country to do. It's called the HOPE note. This stands for Healing-Oriented Practices and Environments, and it addresses these four dimensions that I mentioned before. The central one, you'll notice, is spiritual and mental, the existential question of what matters to you in life, okay? Not what health outcome do you want right now, but why do you want to have a health outcome of that type? What are you going to do with it in those areas? Why are you here in those areas? So it starts with what matters, and then it looks at the personal determinants of health, those things that are 80% outside the box in those areas. Here's an example of some of those tools. And the personal health inventory is a 2-page questionnaire that you can actually download from our website and do right now. It's extremely helpful personally, even if you're not in a visit with a doctor, even if you're not a doctor or a nurse, and in helping you organize your thinking about the underlying determinants of health and aligning them with what matters. If you do it with your doctor, if you take it, bring it in and say, hey, I want to talk with this about, you're doing essentially an integrative health visit. Hope note is what would come out of that if they've been trained at it. And this is what I did with Cynthia. And we're training people to do that in a personalized health plan. We've got a very large set of growing resources then to support those recovery services I showed you on the 2-circle model are available, and they're all available free, can be downloaded, can be used immediately for personal healing and for an engagement with your doctor. Here's an example of that built into a number of systems in their electronic medical record. You do an integrative care solutions guide. The discussion identifies the top area you want to address, for example, stress management, and then resources, technologies, and come out of that. So this has been applied in primary care, and we've just completed a 16-site learning collaborative around the country. Here's a list of some of the sites that are involved in doing this, and a report on that is about to come out in terms of what they found useful, not useful, how they need to adapt it. We've also added and are in the process, adding additional specialties and additional systems in those areas. Here, for example, is an integrative oncology leadership network that is applying and adapting these tools to cancer care, another area where the treatment of the tumor becomes the sole focus and the patient tends to be neglected, even though the science and the evidence and even the guidelines from major organizations say we should pay attention to some of these other components. There's a network of groups around the country excuse me, that are doing this. Okay. Finally, demonstrating value is very important. And I see that because of I added in the Davidson group, I'm getting a little bit behind here, but I want to show you that you've got to have accountability in this area. If you're going to build a better mousetrap, you better show that it actually catches mice better, right? How do you know that it's actually of value? Well, we do know what that is. There's a set of outcomes and metrics that are well established within healthcare. They go by the name the quadruple aim. They are better patient outcomes, lower cost per person, improved patient experience, and improved clinician experience. The problem is most people don't actually measure all those outcomes. They sacrifice one often in order to get the lower costs in those areas. And so you have to see simultaneous improvement in all of these. COVID has demonstrated to us that if we don't add an additional outcome to that, we will never get to health in the nation. And that goes by the name of equity. And that's because of the major increase in disparities that was occurring even before COVID, but has been rapidly accelerated in those areas. We've done an overview of the business case looking at each of these outcomes. And I don't have time really to go to all through all of them, but I'll show you a few of them. Here's an exemplar, the VA Whole Health that I just mentioned, that has shown reductions in costs by over 20%, opioid use, perceptions of care, better engagement, and overall well-being. And I'll show you a little bit more about that in a minute. There's a South Central Foundation, a major hospital up in Alaska, taking care of Native Alaskans, that has for nearly 30 years shown that this kind of whole person care model actually has continuous improved health in all of the outcomes that I've just shown you. And here's a list of some of those. They don't call their patients patients because they actually own the system. They call them customer owners. Interesting phrase and an interesting twist in thinking. University of Arizona is involved in that. I'm going to skip over some of these things. Better patient outcomes. Geisinger is involved in that with some very simple programs like providing food and education to diabetics that are not under control, and showed it significantly improves their control. This is consistent with the diabetes prevention study that showed that lifestyle is much better than drugs for diabetic prevention. University of Michigan. I'll go back to the costs in a minute because I do want to open things up and allow questions to come through. The diabetes prevention program I mentioned here, and notice the difference here. This is preventing diabetes, which, as the obesity epidemic, another epidemic that has gotten worse during the pandemic, especially among our children, we have had increased risk of prediabetes that develops other diabetes. And they showed that lifestyle changes, the kind of stuff we've talked about here, can do an 11-year delay and 20% less total incidence compared to the best drug we have for this at this point, which only produced a 3-year delay and 8%. And it was significantly less expensive. Here's just a little bit more about lower costs from the VA. They're the most robust large system doing detailed analysis of this. I already mentioned the almost over $4,800 saved per person who engaged in a whole person care model. That was 24% lower costs overall. The drug costs increased, but at a much lower rate than those who didn't use it. And a recent publication I've listed at the bottom, actually out just a few weeks ago, showed that if you extended those cost savings to a national healthcare system, we would save the equivalent of $1.1 trillion, which, depending upon who you ask, is somewhere between a fourth to a third of all healthcare costs. Improved clinician experience is important. Equity is important. There's not been as much research on that, but they have shown that providing for some of the social needs can reduce healthcare and medical care costs. Here's an example of one of those in which one social need was met. If all the social needs were met, they had a 10% drop in healthcare needs. Makes sense, actually, in those areas. All right, so what can you do on Monday? And it doesn't matter if you're a system leader, if you're a healthcare provider of some type, if you're just a person. We're all just persons in healthcare that has experienced healthcare. And I've noticed all of you look exactly like you did at Davidson, so none of you have any problems, I'm sure. You can do a number of things on Monday. Anybody listening to this talk can download the personal health inventory from my website. It's totally free, and go ahead and take it. Very easy, takes about 10 minutes. It helps you identify where's your health now, what's important for you in your life, and where are the key determinants that you might want to focus on. You can take this in and go over it with your doctor if they actually want to do a discussion of this. There's a whole guide on my website on how they can do that. If any of you have chronic pain or have or deal with chronic pain, patients like Cynthia, there is a free CME course that you can take online developed by Tufts University that shows you how to apply these things in chronic pain. If you're a system leader, I've already showed you, take a look at the two-system model. There's going to be a publishing coming out in a major journal in about a month that actually describes it in more detail. And just go to the website. I am so fortunate that I am supported by a nonprofit foundation that just wants to get this out. So I have no financial conflict or in any of these areas, and everything on the website is totally free and available and adaptable to those areas. So again, thank you everybody for allowing me to talk about sort of my experiences both at Davidson and how those had an influence on what I do now. And I hope this was interesting and helpful for you.
Thank you so much, Dr. Jonas. This has been so helpful and enlightening for all of us. We have a couple questions, and So I'm going to start with one. This comes from Melina Phillips, and I apologize, Ms. Phillips, if I am pronouncing your name incorrectly. What are some ways to improve health given the lack of social structures in diverse communities, i.e. not having both parents in the family dynamic, not having education regarding sexual health, and having an increase in healthy, and I think there was a misprint, but in general, that is the gist of the question.
The question was, how do you do this, especially in underserved communities that don't have social resources? Yeah,
Yes.
extremely important question. I mean, I showed you the graph in which the behavior and lifestyle is, contributes to health, and then the social and economic components. But the reality is, if you don't have the social and economic components, you can't do the behavioral component, right? Or often can't. Now, I have patients that do it, even if they're in those environments. But those are multiplier effects, and this is the problem. I mean, if you look around the world, okay, a lot of the rises in mental health that we've seen with the pandemic, the death rates that we've seen in the pandemic, some of the outcomes that I showed you from the National Academy report, including things like maternal deaths, which is we are atrocious at. We're like sub-Saharan Africa in terms of our maternal death rate. It's absolutely embarrassing. These come because we do not invest in these underlying social components, right? Now, the healthcare system can't be solving all of those problems, but they have to be part of the solution. They actually have to have risk-adjusted and social-adjusted support so that they can access those community services and actually not ignore them because they say, well, we can't pay for them, or we don't know how to find them, or something like that. There's a whole network of groups that do this. They're called community health centers, or FQHCs, and they are chronically underfunded, constantly looking for other support to do that. And data has shown that countries that actually fund those kinds of social services have not had the rise of costs, and they have not had the rise in suicide rates, opioid components, nearly at the same rate as we've had in the US. So we have to be realistic. We have to use the science and say, here's what the determinants of health are. Let's make sure our system can actually provide and address those determinants of health. So I hope that answered the question.
One just came in from Marty Smith-Sharp. Wayne, how can we as individuals help advance the concepts and improvements to the system you are discussing? Not disgusting.
We're disgusting, yes. I think there's several very simple ways you can do that, and I have a lot of these on the website. I mentioned one at the end, which was take the personal health inventory so you can see how it occurs. Next time you go to your doctor, say, hey, I'd like to talk about my underlying determinants of health. Okay, what is that? Print out the description, we have it on the website, and hand it to him or her and say, I'd like to have a discussion about that. Here's my personal health inventory. And if they say, well, I don't know how to do that, then show them the website, and all the instructions for do it yourself is how to do that. We have a lot of people around the country that have just picked this up and doing it, especially residents, young people, fellows, et cetera. They want this, they need to know how to do it. And so we have a lot of how-to tools and resources that can be used immediately without, a lot of the same kind of resources the VA has, for example, that I showed you earlier. So the thing is just to begin, okay? Start now, do it, use some of the tools, have the conversation, say, I want to address my underlying determinants of health. Maybe it's not just a switch in my prescription or a new procedure. Where do I get that in those areas? And now that COVID is waning, they'll maybe be able to address some of that.
Well, we have not. Oh, actually, one just came in, and I apologize. I've heard that my it's kind of hard to hear me, so I apologize if I sound a little fuzzy. The country has been trying to transition from fee for service to value-based care for several years now. How do you see that being accomplished?
Yeah, well, it's going to be hard. And the reason it's going to be hard is because we have a structure and a healthcare industry that makes a lot of money on not doing it. Okay. And so there are vested interests and conflict of interests that if we really moved in that direction fully, would resist and have been resisting for that. And that's one of the reasons it's been difficult in those areas. Instead, we've been sort of taking little bites at it, okay, in those areas and incrementally to do that. My hope is that COVID, for all the terrible things that have happened while we've been in this pandemic, has created a readiness for transformation. And the National Academy, for example, now has an entire transformation series that it's about to come out with that starts with what COVID has done to the health of the American public and our healthcare system, and is trying to use that to leverage a shift to the value-based component. I showed you the study that we're funding with other foundations called Financing for Healthcare in those areas. And I think that will add to that area. I think another thing is that, it's not just about the government paying for this. In fact, a large percentage of the population is employed and they get their healthcare insurance paid for by their employer. Financed healthcare by large organizations, for example, they're shelling out tons of bucks on this. Wake up, okay? If you're not getting value for all the money you're paying, have somebody work with organizations like ours and many others that are out there to say, how do I get the right money? How do I get the right value, from the money I'm doing? And I think the private payer, okay, the private corporate payer has now shown, there's excellent examples of how they have begun to pay for something different along the lines of whole person care and reduced the amount of money they actually have to put into healthcare. And so I think, this isn't just going to a universal healthcare system. This is saying even the private systems can kind of do this. And there's lots of examples of that also.
Great, thank you so much. We have probably time for one more question. And Becca Simpson had asked a great question, but I just would like for her to elaborate a little bit, Becca, because I don't want to speak out of turn of what she really wants to know. Becca, if you wouldn't mind unmuting yourself if you are able, and you can ask Wayne your question.
Okay. Can you all hear me?
Yes, thank you.
My question was, what's going to be the incentive for the primary care physician who, and my husband learned is increasingly under time pressure to see more and more patients?
Yeah, well, the reason he's under time pressure is because he's spending a lot of time in increments and is paid for his transactions, okay?
Right.
And so redesigning the system is what will solve that problem. And I just showed you how we're attempting to work on that. Now, depending upon the system he's in, the openness of the leaders in those areas and what kind of contracts they want to go after, okay, where they want to get their money, they can actually take full risk and say, all right, we're going to do this better, and we're going to take full risk. And the ones that have done that have taken full risk and redesigned their system along the lines that I've shown, have actually made money, okay? So his system leaders need to realize that, by keeping everybody on this sort of transactional fee-for-service basis, they are losing money. It's not a matter of lack of money. It's a matter of how and where it goes. And so, he can begin the process in his own practice. I realize that's difficult if the leadership says I won't do that, but we are working with a number of systems one up in Queens right now, okay? Huge safety net hospital that is transforming their entire system over to this two-circle model in those areas. And CMS and the state of New York and others are keeping a very close eye on that to see, can they actually demonstrate both cost savings and improved outcomes? And if so, then they'll jump in. And of course, as you know, as CMS jumps in, others tend to follow. But he can do that in his own system. Set up an integrative practice unit, okay? Do it as an experiment, okay? Say, we're not going to do the entire system this way, but I want to take this one unit and I want to test this new way of approaching. In fact, Foundation's looking for organizations that would like to formally test sort of the redesign of the system, you know, in healthcare systems that are interested and ready for this.
So would you call that a win-win for the insurance and the primary care physician?
It's a win-win for the
Patient, certainly.
It's certainly a win-win for the patient. It's a win-win for the healthcare providers. You know, it can be a win-win for health insurance, because if you're delivering better healthcare at lower costs, then they're not chucking out as much money, right? And so, and it's certainly, if they whoever's paying for that insurance, you know, private payer, Medicare Advantage, or whatever, you know, it's a win for them too. It's not a win for the services you now don't need, right? And so if your entire system is based on how many brain surgeries and cardiac surgeries, et cetera, that are complications of things that you could have prevented, then it's not going to be, it may not be a win for this hospital system. And hospital systems, when they've seen some of these things come in, they've often gone out, you know, purchased them and squashed them because they see a decline in their bottom line, because they're making so much money off of the end game rather than the prevention game, okay? And they don't want to change that. So that is just morally undefensible, in my opinion. It's economically sensible, but it's morally, you know, inappropriate.
Wayne, we have had a couple more questions come through, and if you have a couple more minutes, I'd like to be able to ask them, if that is okay with you. If not, I can email you and I can send it out at a later time.
Happy to do so.
Wonderful. So the first question is, how do you facilitate communication between providers who are in different health systems and with different EMR?
Okay, can you repeat that question? I missed it.
Sure. How do you facilitate communication between providers who are in different health systems and with different EMR?
Wow, major problem. Okay. How do you facilitate? I don't have a solution for that, actually. Okay. You know, I think in the recommendations that the National Academy made to the administration, and that now they're building in to their primary care transformation process, they have an entire section on technology. Okay. And the technology has to have several changes. And we actually have the technology to do this. It's not like we couldn't do this. We actually can do this. So there's a couple of changes that have to occur for that to, to actually happen. One is that we actually have to have a software ability to make that link easy, you know, and wherever, and it should be under the control of the patient, still a healthcare system. Okay, in those patients, so that the patient can own that. It can be linked to, a smart device. It can be linked to their watch. It can be linked to that. Where all that information, some groups are doing it as a card, where all that information is there. A card where that information can be downloaded off of disparate systems is actually out there being developed right now. That would be another way to do it, where you could bring your card in, scan it like you do your credit card, and whoever you're there with can see the entire history in those areas, and hopefully the patient can see in those areas. But that's not going to be enough unless we insert some of the underlying determinants of health that I talked to you about before. So the nature of what goes into that record has to be different too. There's some great health systems that have tried to do this whole care person model within the current electronic medical record. And they found that they had to jettison it. They had to build one because it wasn't person-centered. It was medical-centered, okay? So it actually didn't identify who needed the right care at the right time, so the team could come in and say, I'm gonna go out and solve this problem that the person needs right now, okay? And so they actually had to redesign it to be whole person in those areas. So we need two things, the link, okay, the download from any site, okay, like your credit card, until we have a single system that already links things up appropriately. And the second thing is the information that goes into it needs to truly get at the determinants of health. And so that information, like I just described to you, needs to be part of the record.
Great, thank you so much. And the last one for today, does the VA Mountain Home in Johnson City, Tennessee have the whole person care program?
Yeah, so I tried to answer that online. I don't have access to the website at this point, but if you go to the VA website, and I think the link, but if you just Google it, you'll find it, or search for it, you'll find it. It's called VA /whole health. That's all it is. Okay, .gov, G-O-V. I think I didn't put that in my reply back. So it's VA whole health, G-O-V, or just Google whole health VA, Veterans Administration, and it will pop up at the top. On that site, they list the 18 major sites where they've been investing in developing centers of excellence, the 56 others that they're rolling out right now, and where these kinds of resources can get accessed at different VAs around the country or remotely. The VA did remarkable in setting up remote care. They were already on that track beforehand because access was important for veterans who lived far from VAs. And so now that's been incorporated into this type of care. So I would go to that site and look to see whether the Jackson site can do that. And if they don't, go into the Jackson site and say, hey, why don't you access some of these resources? They're already there and they're already free. Why don't you make them happen?
Wonderful. Thank you all so very much. I'm going to pass it to Judith, who is going to kind of wrap us up for our session.
Great. Thank you, Lauren. And a ginormous thank you to Dr. Wayne Jonas, class of 1977, for today's excellent discussion. Wayne, we're going to be sure to share the love with you that we've been receiving on your behalf for such a wonderful presentation. Folks are very grateful for the information and your time and willingness to share. They are definitely asking for your slides, so I'm happy to share that Wayne has offered that we can share the slides, and we'll be sending that out in some post-event emails that y'all will receive. So do know that those are coming your way. Wayne has also offered, if you've submitted questions that he was not able to answer, we're going to go ahead and share that with him too, and he'll do his best to reach out and respond to you. We are recording, we have recorded this session today. And so in about 2 weeks, it'll be live and on the website for everyone to see and enjoy, and you can share with folks who did not have the great pleasure of joining in with us today. So happy to continue sharing the love and the wonderful information. We again are incredibly grateful, Wayne. Thank you for all that you do for Davidson and the larger community. We're very blessed, and appreciate everyone joining, and hope that you have a great evening.
Well, thank you. It's really been a pleasure. It's great to see some of you again. Nobody's changed a bit. So you all have a great day, and looking forward to see you at the reunion, hopefully.